Respected chairpersons, moderators, panelists, and participants, very good morning. And it's my pleasure to be introduced here as a case presenter today. My case is a young lady with prosthetic mitral valve. Let us see the patient's initials. Mrs. X, 35 years female, normotensive non-diabetic, presented with shortness of breath for 7 days, which was progressively increasing to New York Heart Association class 4 at presentation. She was diagnosed previously as a case of chronic rheumatic heart disease, severe mitral stenosis, and severe mitral regurgitation, and underwent mitral valve replacement surgery with a mechanical prosthetic valve 4 months back. She had a history of irregular intake of warfarin after surgery and stopped warfarin for last few days of presentation. She had no history of fever. Regarding examination, she was generally dyspneic and restless. Cold and clammy skin was found. Respiratory rate was 36 per minute. Pulse rate was 120 beats per minute, which was regular and small in volume. Blood pressure was 70/40 millimeter of mercury, and precordial auscultation reveals absence of metallic sound with a mid-diastolic murmur, and bilateral fine basal crepitations were found on lung examination. In this point, our clinical diagnosis was acute mechanical prosthetic mitral valve thrombosis. This is the ECG of the patient, which showed sinus tachycardia and right ventricular hypertrophy with a strain pattern. Now, what is the recommended diagnostic approach for a suspected mechanical prosthetic valve thrombosis? This is the 2017 American Heart Association, American College of Cardiology focused update of their 2014 valvular heart diseases management guideline. Their class 1 recommendation was urgent multimodality imaging with transthoracic echocardiography, transesophageal echocardiography, fluoroscopy, and or CT scanning. This is the urgent transthoracic echocardiography we did in this patient, and the 2D findings showed the mitral valve leaflets are thickened, prosthetic mitral valve leaflets are thickened with less mobility. The color flow imaging showed obstructive color jet across the mechanical prosthetic mitral valve. And the transprosthetic mitral valve gradient, peak pressure gradient, was 45.6 millimeter of mercury. It was significantly raised for clearly demonstration of the obstruction. We took the patient under fluoroscopic examination then and found that one leaflet of the prosthetic mitral valve was nearly fixed and other leaflet had restricted motion. Our question was that, was it thrombus or pannus? Transthoracic echocardiography has less sensitivity in differentiating between two, but with the clinical correlations, we had found these points in favor for thrombus.
Sorry, Iskirai, please finish within 2 minutes.
Yeah.
Okay, and this is because Jumma prayer time.
Okay. I will finish. There had a history of irregular intake of warfarin after surgery. She stopped warfarin few days before the occurrence, and short period of onset of surgery, more acute in onset and not so more echogenic the structure was. What could we do? The current guidelines class 1 recommendation is urgent slow infusion low dose fibrinolytic therapy or emergency surgery. And the European Society of Cardiology current guideline also is telling that if the surgery is available, then surgery to be done, and if surgery is not available, then fibrinolysis to be done. What we did, we decided for fibrinolysis, as because our patient was hemodynamically unstable, there was little time in hand, patient denied surgery, no left atrial thrombus, no contraindications for fibrinolysis, and it was the first time episode. And according to the current guidelines, we had got more points in favor for fibrinolysis. We treated our patient with low-dose slow infusion regimen of injection streptokinase, that is injection streptokinase 250,000 international unit bolus in 30 minutes, followed by 1 lakh international unit per hour up to 24 hours. And the current guidelines class 1 recommendation is slow infusion fibrinolytic therapy has higher success rate than previous high-dose regimen, and it is effective in patients previously thought to require urgent surgery. This is the echocardiography done at 24 hours of fibrinolytic therapy. the transprosthetic mitral valve peak pressure gradient became 26.4 millimeter of mercury, which was less than half of the initials. And after fibrinolytic therapy, patient was clinically improved, no sign of systemic embolism, no sign of bleeding, and low molecular weight heparin was started to reach the target INR, and warfarin was started accordingly. And it is the echocardiography done on the 5th day of the fibrinolytic therapy that 2D findings showed the mobility of the prosthetic mitral valve leaflet is increased, and the transprosthetic mitral valve peak pressure gradient became 9.1 millimeter of mercury, which was a great success of the fibrinolytic therapy in this case of prosthetic mitral valve thrombosis. So in take-home message, I'd like to say that high index of clinical suspicion is important in requesting urgent echocardiography for suspected cases of prosthetic valve thrombosis. Careful echocardiography is used to diagnose and assess the prognosis of fibrinolytic therapy, and fibrinolysis may save life in a critically ill patient with acute mechanical prosthetic mitral valve thrombosis. Thank you, sir. Thank you very much for patience hearing.